Thank you very much. What Dr. Lubetsky and I are going to be talking about today is what we'll discuss, obviously, the issues regarding psychiatric conditions, psychiatric diagnosis in individuals with autism spectrum disorder. And we'll talk a lot about the challenges, obviously, if you've been involved, depending on the level of ability of the person that you are having evaluated, determining a psychiatric syndrome in that individual. Because as you'll see, a lot of the behaviors that are presented, chief complaints, often are misunderstood. We heard early in the morning with the keynote that some of the co-occurring conditions, ones that are related to medical conditions, are often misdiagnosed or represented as some kind of psychiatric disorder, somebody who may be self-injurious behavior. And the etiology of that could be seizures, it could be some kind of pain, or even sensory stimulation in some way. So the challenge for clinicians, there's a variety of them, challenge for clinicians is to kind of separate the two. We're talking about co-occurring or dual diagnosis, and that basically is two conditions in one person. And we'll clarify that and define that as well. The other things that we'll talk about in looking at the diagnostic process, again, referring to the keynote speaker, the issues of, there's a term it's called diagnostic overshadowing, and that simply is somebody who's presenting with some psychiatric symptoms or even challenging behaviors. And if you don't understand autism, everything's related to the person having autism. So that's referred to as diagnostic overshadowing. We'll talk about that and how to differentiate that. Also, functional behavioral assessments. Probably heard that a million times. What I try to do is give people an understanding of how that might be used. Really, out of the typical ways of looking at escape avoidance and attention, I try to look at functional behavioral assessments that kind of go beyond the unobservable. So when you have people that will present as maybe they'll have some disruptive behavior, aggression, self-injury, and you may ask someone, well, why do they do it? And you'll hear things like, well, it's out of the clear blue. It's just typically rare that somebody does anything out of the clear blue. But if you know how to assess behaviors, what to look at, situations, circumstances, responses that the person has in different situations, you can get beyond the behaviors being related to attention or escape avoidance. The other thing is we'll talk about treatment principles. It's, again, very important when you're working with persons with dual diagnosis, especially folks that are more involved severely. As we all know, the autism is a spectrum disorder, so we have individuals that are gifted, superior range of intelligence with psychiatric disorders, and we also have individuals that are severely and profoundly intellectually involved, nonverbal. You know, how do we determine that the aggression that they're having or self-injury is an expression of mania or depression? But we can do this, and hopefully I'll be able to explain a little bit of how that process works. And also taking into account the processing of the individual. So anybody that has any mental health condition, your processing's affected. Whether you have mild depression, concentration, memory, you're probably more irritable. But again, most people that are higher on the spectrum are able to tell you that. So we, people that have Asperger's that are being evaluated for depression, you can simply use some of the standard scales in your interviews to determine that. They can actually tell you that. But the presentation also involves people that are, again, severely involved, and they are nonverbal. So how do we get that information out of them? We'll talk about that. And then best practice. How do we design programs in this day and age with regards to interventions? Now, I'm just going to talk about a few of them in that segment. Basically, the counseling, some of the therapies that are prescribed for people who may have social phobia or anxiety, because those are kind of primary issues for a lot of our adults that we see. So we'll give you some information around maybe the type of therapist or the therapy that might be involved. As we go through some of these treatments and talk about the interventions, we hear through every presentation that there's no one single cause for autism. And with that, there's no one single treatment. So you'll see as we talk, and you probably may be involved in a variety of treatments that may be atypical, not standard, not even in the literature, but may have some effect. So we'll talk about the best ways to at least approach interventions when you're trying to choose one. Which one would you choose first? And then Dr. Lubetsky will wrap up later on just a few minutes on the medication issues. We was presenting earlier this morning. Same issues actually are with the adult population as well in terms of how to monitor, how to measure side effects. All of those things are important to know as well. So here's the overview of our presentation here. As I said, these are two conditions occurring in one person. Assessing psychopathology, for people that are more severely involved, have limited opportunities through life. You'll see that they probably will develop or have symptoms of depression probably in their teenage years, especially adults as well because of their experiences. Treating the underlying symptoms, so there's how do you, first of all, if you identify the problem, when do you choose a medication, when you do behavioral programs? We also heard that behavioral interventions always go first. And I have a motto that I stand by is motivations before medications. It's the first thing that you think about. What's the etiology before you get the prescription pad out and start prescribing medications for some of the behaviors. So dual diagnosis, two conditions in one person. So this simply is important to understand because the treatments and the interventions are going to be different for each of those conditions. So what we know about autism spectrum disorders, it's neurological impairment, and we heard it all through the presentations, the core features. We have communication deficits, we have social skills deficits, and these restricted patterns of behavior. Nothing related to mental illness here. These are just deficits the person has interacting with their environment and socializing. Mental illness, however, as you see, refers to this severe disturbance in behavior, mood, thought, and social and interpersonal relations. So when we think about autism, and we think about some of these mental illnesses, they actually have overlaps. So when you're looking at people who may even be diagnosed with schizophrenia, and some of the negative symptoms of schizophrenia, which, lack of decrease in ADLs, limited eye contact or interaction, relationships are poor. So those are some of the negative things, not necessarily hallucinations and delusions. So when we look at these two conditions in one person, it's real important to differentiate and identify those. And why do we need to do that? The impact of this comorbidity, we heard this early on, just with healthcare costs and utilizations. If you have these co-occurring conditions, you see that you're likely to be in the hospital more frequently. You'll be in and out of multiple placements, depending on your behavior and when it's first identified. Also, if you have severe behavior problems, you're going to be on multiple medications, sometimes 2 and 3 medicines from the same drug class, which is obviously a concern. So those are questions should be asked if that's the way that somebody is medications are prescribed. There's likelihood of medical complications as well. And we see a number of adults currently that have been on medications, and there's issues with they have heart conditions, they'll have glucose, blood sugar problems, so we have difficulty with teaching them how to take readings. So there's a number of medical conditions. You heard about seizures as well, 30%, up to 30%, of some type of seizure disorder. So these complications also are something that need to be evaluated and assessed. So unmasking these psychiatric syndromes or disorders is a challenge. And even though there's the growing number of people that are identified, and we know that people on the autism spectrum disorder will have more mental health conditions or concerns than the general population. It even starts from early elementary school and all the way through adolescence. So when we talk to some of the folks that we evaluate, you'll see that they're often limited or restricted opportunities to engage in activities through life, oftentimes victimized. So even when we're looking at post-traumatic stress disorder, which a number of the adults that we evaluate will say that they've had some trauma experience. And obviously that brings a whole different type of intervention if we have trauma histories. So clarifying the diagnosis with these degrees of autism, higher functioning folks, it's still a challenge, but they're able to tell you, you know, the medicines are working, or I feel a certain way. And even at that, even when we have people that are superior range of intelligence, putting feelings to words is a challenge. It's very difficult. But with the higher degrees, in terms of mild and Asperger's, they're able to use standardized scales, give us information. And for these folks that are more limited or severely involved, according to DSM, it requires you to do a self-report, or how do you feel? When do you get these feelings? And obviously for someone who's nonverbal, they're going to have difficulty telling you that. So that's the clinician has to really rely on information from others for accuracy. So as you'll see, it's difficult to do a psychiatric evaluation in a 45-minute visit for somebody who's severely and profoundly intellectually involved in having aggression or self-injury, irritability. The other thing is the poor insight and judgment. So when we ask someone about, you know, again, their feelings, or do you feel depressed, oftentimes you'll get behaviors, and this is very important. You'll get a description of the behavior. I do this, as opposed to the feeling of depression, anhedonia, not interested in activities. It's hard for someone to kind of explain that, but if you watch them and you see that there's a change in their baseline, or it's a change in the way that they behave, that's a beginning sign to look at it. As you'll see as we go along, one symptom or behavior, regardless of the intensity, is meaningless from a diagnostic standpoint. You have to have, in order, again, to get the psychiatric diagnosis, a cluster of behaviors and symptoms that go around it. That's why you call it a syndrome. So as we look at these optimal diagnoses, developmental and family history are critical. On adults, so if we're talking about our adults that get evaluated, we have a number of people that have been in the mental health system. In terms of treatments, they may have entered in when they were 15 or 16, and they may be 30 or 40 and have 5 or 6 different diagnoses. Nothing's worked. Medicines don't work. The therapies don't work. When you get that kind of profile or pattern, then you really have to look more closely at an autism spectrum disorder. Somebody hasn't figured it out at that point in time. So developmental history is key in terms of identifying any of the depression, anxiety, and then obviously the family history as well. History of behavioral concerns, both chronic and acute. What we're looking at, or what anybody should be looking at, is a change in a baseline, either an onset, something person was okay, there was an onset, something occurred that's changed in terms of how the person interacts, more isolative, more keyed up, lack of sleep. So there's a change in that person's life. Or you'd have a regression. Somebody's doing very well, and then you have, again, this deterioration in the person. So those two things you're going to look at. The answer to the chronic and acute, that helps us differentiating something that may be related to personality issues, something that is long-term ingrained. Somebody's anxious all the time. They just had an increase or an exacerbation in their anxiety, which may be a key to depression or an increase in an anxiety disorder. But so we're looking at any of these changes over time, as you see this departure from the baseline. And then for any of the mood disorders, we're looking at episodic courses. So whether it's depression or anxiety, we're going to be looking for those periods of wellness. So if you look at somebody's history that has bipolar or some kind of a mood disorder, that you'll see that there may be stabilization for a year, year and a half, and all of a sudden you get this deterioration, and then maybe another year they may be doing okay. So you're looking at these periods of wellness and monitoring, because that's very important in terms of using medications and interventions. And then the current mental status. And that's also a challenge for clinicians. You know, looking at mental status, everything from How does a person appear in your office? I mean, if you work in the field of autism, there's some very interesting ways that people dress when they come in, or things that they bring with them. So somebody that has a passion for dustbusters, they maybe bring a dustbuster in. You know, if you don't know what you're looking at or understanding, you may be off and running with something atypical or unusual. So when we look at passions and psychosis, it's very important to differentiate those two things. And you can, and you'll see it a little bit later in the presentation. Hopefully you'll be able to see that. So from the clinician standpoint, the issues or the types of errors that we're concerned about, obviously, if you fail to identify the presence of a mental health problem. So what happens if you don't identify it? Or so it decompensates, you're not getting treatment. Often additional other psychiatric symptoms will come along the way. If you have anxiety, you may develop some depression or other things, depending on how severe the depression is. They isolate. You're more likely to have restrictive interventions and actually end up in the hospital if it's not treated, if it's not identified. On the other side of it, making an inaccurate diagnosis, which actually happens, I don't want to say a lot, but if we look at the histories of the adults that come into our clinic and just look at the trajectory, and you're going to hear or see things like ADHD, oppositional defiant disorder, we'll see anxiety, we'll see mood disorder, in some cases conduct, but which is rare, but you'll see that as well. So these things will occur, and the person really has had these different layers of diagnosis and medications and a variety of other things. So what's important, obviously, is to try to get the accurate diagnosis. And we're talking about individuals who I guess they fit the definition of complex needs, or they cut across systems. So as we saw earlier in the presentation, it's just not one thing that goes into the chief complaint or presenting problem. So somebody that's aggressive or self-injurious. It could be everything from where the person lives to medications, side effects. It could be sensory areas. So all of those things really need to be addressed. You're also going to look at lethality or severity of the problem, because if there's obviously somebody's intent to do harm to themselves, then you're going to probably have to do something a little bit more quickly. But in most cases, you should spend a little bit of time to kind of figure out what's going on. So the risk is you see the making of an inaccurate diagnosis, increase in challenging behaviors. Even the medicines are something that can create bigger problems for you. And then the use of PRNs and the polypharmacy. So this goes without saying. People on the spectrum, at any disability or disorder, really, no two individuals are alike. The day and age of protocols, if you will, or interventions that fit, one size fits all, that should never be happening in anybody's treatment plan or program. Treatment's all individualized. It's individualized to the person and individualized to the etiology or reasons why they are presenting with these concerns. And we also treatment is multifaceted, multidisciplinary, as we said, that cuts across a variety of systems. So in a lot of cases, you're probably going to need some communication with neurology and psychiatry. And we have some of these issues with some of the folks that we work with, in that there may be 2 and 3 physicians that are writing medications for the person. So you have a PCP that's writing medications. You might have a neurologist that's writing anti-seizure medications, but then you may also have a psychiatrist who's doing mood stabilizers or anticonvulsants. So the combination of those things can actually create problems. So it's communication, especially when you're having somebody with these kind of multiple concerns. And then the accurate diagnosis, as I said, it requires time and teamwork. So it is important to get as much information as you can before you begin to design some kind of treatment plan or program. So this is an older study. However, This really holds true for most clinicians that are doing evaluations. So when this is again one of the difficulties in diagnosing. So obviously the intellectual distortion. We talk about labeling things. Tell me, you have anxiety. Somebody comes in the office and say, well, I get heart palpitations, I'm sweat, my palms are sweating, and I get overwhelmed, I shut down. That's a typical kind of answer that you'll get, but somebody on the spectrum, even with somebody who may have superior range of intelligence, you may hear something like, I feel like I'm a needle in between two bricks. I mean, that's a description, and just think about what that feels like. So the descriptions are pretty literal in terms of what that feeling is like. But again, if you didn't understand what that meant, and if it's anybody that you're doing evaluation, if you don't understand what somebody's saying, don't make assumptions, ask, press a little bit more, tell me a little bit more about what it is. And the psychosocial masking, obviously, even for our adolescents that are having difficulty in school, joining groups, participating in activities, when we do these evaluations, they often they have this suspicious look about them. They're nervous, they're anxious, they won't give you eye contact. And unless, again, if you didn't know autism, you'd think that there's something really unusual going on with this person that would lead to, again, a psychiatric diagnosis. In this cognitive disintegration, these are the meltdowns that people have sometimes, and also this idea about processing. So you see this self-talk, imaginary friends, but the self-talk it's interesting. We even have very high functional. How many of you self-talk when you're overwhelmed? So there are even interventions. Jeffrey Wood and his programs out in California actually have an intervention of self-talking, talking yourself down. So you would think that person talks to themselves, then they may be operating from some kind of internal stimuli, and that's not the case. It's thinking out loud, because we do again know that the executive functioning is difficult. The ability to hold a lot of information in your head at one time, sequence and abstract information, especially when you're upset and angry, is very difficult. And you would think that somebody who's very bright would be able to do that, but that's not the case. So these are some clinical issues. In terms of the diagnosing, the principles. So when we look at people with autism, they can get anything anybody else gets, whether it's psychiatric, medical, so it doesn't immune them. And this is where the diagnostic overshadowing comes in. So you have to understand that even though autism may be a primary area, there are other things that you have to assess and look at as well. Psychiatric disorders usually present as maladaptive behaviors. A lot of people that come in for evaluations, in some of the literature tells us that the ones that present, obviously, in the emergency room are destruction of property, aggression, and self-injury. Those are the three major areas that usually people will show up in the emergency room on the behavioral health side, and sometimes medical because they hurt themselves while they're engaging in that behavior. The origin of, obviously, the psychopathology is multi-determined. Developmental issues, restricted opportunities, poor social interaction, all of these things through life can actually lead up to somebody having anxiety and depression along the way. And you'll see even with the treatments, when we talk a little bit about treatments, it's really important to know what's going on at that moment in time. Even though some of these behaviors, anxiety, could be started when somebody was in adolescence and they just continued along the way. You have to understand that that's where it started, but the treatment and interventions are really going to occur what you see at that point in time. Acute disorders present as exaggeration of long-standing problems. So somebody who increases in their self-injurious behavior, all of a sudden it's a different level, it's more intense. And that's just one thing. Remember what I said about one behavior. As you see here, one behavior by itself doesn't mean a whole lot. And even the severity of it. So if somebody's really self-injurious and they may do some physical harm to themselves, from a diagnostic standpoint, you can't call it anything. It needs treatment. You need to do something about it, but it doesn't meet level for depression or anxiety until we look at the other things. What's the sleep like? What's the affect like? What's the What's the irritability like? All of those things should be answered. And then once you begin to get those things together, those clusters of symptoms or behaviors, then you can begin to diagnose. And as you'll see, why is it important to diagnose? Because that drives the treatments. That tailors your treatments. You've got to call somebody something or identify it, and then your treatments are on board with that. So other things to look at, think about. These categories I mentioned before, these are the things that will get most people into the hospital, the behavioral presentations of self-injury. And while I'm on self-injurious behavior, you have to determine self-injury and even self-mutilation from suicidal ideation in some adults. So, and there's a big difference. I mean, you're going to look at lethality, and typically self-injurious and self-mutilation behaviors, in many cases, don't require medical attention. In some cases they do, but it's not to the point where the person wants to kill themselves. But there are others that there is an intent, there's a plan. And you have to differentiate that as well, because some people will say, well, self-injurious behavior, they have a need to kill themselves, or they want to die, and that's not the case at all. By your observation and assessment, you're looking at history, when did it start, that you'll be able to determine. But lethality, obviously, is the primary area that you're going to look at in some of these behaviors. Changes in mental status, and those are things that are critical to look at. How a person looks, what's the affect like? What's the sleeping, as you'll see? What's the sleeping and eating? Has that changed at all? What's the concentration like? They're able to do more, 2 months ago, and now they're unable to perform. If you're working a workshop, 2 months ago, if they're working on piecework or getting paid for the work that they do, why did the paychecks go down all of a sudden? So those are things that will help. As you see also, these medication side effects and these motor side effects are also important things to look at. So approaches to challenging behavior. So when somebody comes in, if you've seen a psychiatric evaluation or involved in the diagnostic process, this identifying the problem, you'll hear things referred to as a chief complaint. It's the reason why they're going to get treatment. And then the next thing, the job of the clinician or the team really is looking at all the things that might go into that presenting problem. And there's a variety of things. I just listed a few here. Everything from quality of life, where the person lives, works, recreates. It could have something to do with the presenting problem. Neurological, medical trauma. We know that trauma is something that needs to be evaluated. And it's a challenge to evaluate that. Again, we're relying on reports from people. And obviously, if there is trauma, then there's a trauma-informed model of care that somebody would have to develop. Addictions and the mental illness, psychosis. So these are things that would be looked at to, again, come up with some kind of diagnosis. Then we're ruling out non-psychiatric causes, and that can be anything just from somebody hurts themselves to communicate, or that they want something, that every time that they want an activity that they'll hurt themselves, or challenging behaviors serve multiple functions. So you may see a behavior, even self-injury, or even oppositional, staying in your room. And you can't, again, make assumptions that it can serve multiple purposes. It could be depression, it could be anxiety, it could be sensory. So taking the time to figure that out, because obviously your interventions are going to be different for each one of those motivations. And we're not talking about medicines here, but medicines can play a part. But you want to first of all rule all of the other areas out. And as I said before, if you obtain, the reason why you're doing that is to obtain a working diagnosis. When I say working, it simply means that diagnosis can change. So somebody actually can come in presenting with depression, and based on the interventions and treatments, it actually can turn into something that may be a manic episode based on the individual, the person. So diagnosis may change over time, and it's the response to the interventions that are going to lead you to the diagnosis. So the psychopathology screening questions for psychiatric conditions, psychiatric diagnosis. This is an important one. Is there a change in the person's behavior that occurs across all settings? So if you are in a full-blown manic episode or you're depressed, it's probably not going to change or leave when you walk through your door to go to the workshop or you go to your employment. It's going to be there. So if you have severe behaviors that occurring in one place and not another, then you probably should first look at the situations, the environment that the person's participating, because that could be one of the issues. You're going to see these expressions of depression, irritability, non-compliance across all settings. Little or no improvement, another important thing. So if you've done a great job in your functional behavioral assessment, you got a great psychiatric evaluation, you design a treatment program and the person isn't getting better. That's a really important part to stop and think, well, we haven't gotten it right. Even though there may be some subtle changes in the person, you really want, especially if you're using medicines again, significant changes. The only reason why you would use that. So we're looking at if a person is unresponsive to any of that, and that can be anything from even doing a neuropsych eval, maybe the interventions, your therapies, the person has some specific learning problem or disorder, and they're really not, it could be working memory, it could be issues with self-regulation that a more involved cognitive assessment may help you out. As you'll see when we talk about our therapies, it's important to know that. So if we're working with somebody who's severely involved and on a contingency management program versus somebody who is superior range of intelligence and has a self-assessment, self-monitoring program, you have to know how do they take in information, how do they process it, and then how do they give it back in a consistent way. So that's why it's important to have some kind of an assessment, cognitive. And that's a recommendation actually from Tony Atwood, a lot of the researchers that are involved in individual and group therapy. We look at this experiencing decrease in adaptive ability. This is really where you're going to look at depression, and you can actually, when I talk about these negative symptoms of schizophrenia, this falls into this category, this self-care, isolation, withdrawal. But it's very important to really look again, when did that occur? When did that start happening? Was there an onset? Has the person experienced decreased involvement in others? Again, the term anhedonia, not interested in preferred activities. And how do you do that? And for somebody, believe it or not, that's severely involved cognitively, they may be walking around with those scratch and sniff or those magic markers that smell, maybe their favorite activity. They always carry it around. It's in their hands all the time. You probably work with individuals if you're on the more involved end working with folks. You'll see that they carry something around with them all the time, and all of a sudden you notice they're not carrying it around. It stays in their room. I mean, those are things, believe it or not, when we go back and look, can you remember when you started to see things change? And obviously, when we're looking at people that are having signs of mental health concerns, you want to make sure you get it on the front side. Because as you see, if you fail to identify it, fail to see it, it will get worse in most cases. It kind of multiplies. So as we're talking about treatments here, this is kind of the schematic if we're looking at the ways that we treat. So we do assessments. We're looking at symptoms and behaviors. So, and when we say symptoms, if I ask people, well, what's anxiety look like in the person that you're supporting? And you're going to hear a lot of different things. I work in a psychiatric hospital and do consults across aging. So if I ask Mildred, who's 88, what's anxiety look like for her, you'll hear, well, she perseverates all the time. She says things over and over and over again. Work with eating disorders. Well, what's anxiety look like in this particular patient? Well, they purge. They'll keep bringing things up. So the idea, the important thing is taking the symptom, and this is the thing that gets treatment, by the way. So under psychiatry or psychiatric diagnosis, you're going to look for symptoms. But it is critical to get to the point where how is that expressed in that person? It's easier, not only is it easier for treatment for everybody, but it's also for the individual to identify. So when you do these things, walk around all day or up on the internet all night long, those are things that tell us you're anxious. So, and if you can tie that into the person's ability to understand that, that's a big key. You'll see in terms of the treatment of anxiety, that's a huge deal. The psychoeducation part of, well, how is anxiety expressed in you? Let's identify it, let's chart it, let's look at it. And now that we know what that is, let's try to teach you when it's beginning to happen, what situations does it occur in, what causes it, and then how do you stop it? So those are parts of, you'll see later on in the presentation, those are some of the ways that we work with individuals to help them overcome some of the social phobia and anxiety. So the schematic here, we do the assessments, we look at the symptoms. Again, we kind of do some detective work to look at differentiating the diagnosis, what's medical, what's not. We have this working diagnosis, and then we design the treatment. Medicine sometimes are involved in this, so you may have a trial of a medication, and Dr. Lubetsky will talk about it a little later on. We're looking at medicines. I think what's important to know, and this is what I tell families and individuals, when somebody's writing the order, the medicines are indicated for something, whether it's an antipsychotic, anti-anxiety. So the questions are, what are we treating here? And again, get beyond the symptoms. So if you're treating anxiety or OCD, well, tell me what OCD looks like in the person. That's what you're going to be monitoring and measuring. The doctor's going to look at anxiety. And then you're going to ask the question, once the person's on the medication, well, how long should it take before we see anything here? I mean, these are questions that, and nobody has a crystal ball, but at least in terms of planning, you're going to get an idea of should we see anything? Because some people think, well, as soon as you take that first pill, then you're going to see the behaviors go away. And that's often not the case, especially even with OCD. Somebody who is ritualistic, and it's beyond the need for structure and routine of somebody with autism. Goes beyond. It's an anxiety disorder. It's OCD. It's somebody who is engaging in a behavior, 1,000 times a day. Taking an SSRI or an anti-obsessional medication, you'd expect to see those behaviors go away. It's not the way it'll work. You'll see a decrease in the intensity. The behaviors are not going to go away. It is really your job, or somebody supporting the person, to teach them something else to do instead of what they're doing. So a lot of people would think, well, just because they take the medicine, that they're going to learn something else to do. And how you know, just an example of how you would know an anti-obsessional medication is going to work, and if it's anxiety related, the OCD, which it is, that when you interrupt and redirect it, you're going to see an increase in that behavior just because the person isn't able to engage in the behavior the way that they want to. But however, if the anti-obsessional medications are going to work, SSRIs in most cases, and sometimes anti-anxiety are also beneficial, you're going to see the person's able to take redirection without an increase in behavior. So that's important for the doctor to know as well, that we still have our behaviors, but they're able to be redirected now a little bit more. They can tolerate a little bit more. So psychopharmacology is important. What do we look for in the response? Hopefully you get a full response. And then the questions, what else can be tried? If you get a partial response, then you see, if you go back up to the top, maybe you haven't identified or defined the symptoms. So as we look at some of these more common psychiatric disorders in persons with autism spectrum disorder, you're going to hear depression, mood disorders, and anxiety. And those are pretty prevalent in a lot of the research and studies. When you're going to see intermittent explosive disorder and impulse control disorders. A lot of the patients, at least the adults that we see, don't meet the true diagnosis of those categories. However, impulse control obviously are these for folks who have these meltdowns or explosive behaviors, or they have these every once in a while, every 6 months or every year and a half, they have this episode. When you get that, they'll typically have an intermittent explosive disorder. However, I should probably say if you have a case like that you have somebody that really loses control and has significant behavioral issues, maybe 2 or 3 times a year, or every other year. You really want to look into maybe some medical etiologies behind this as well, possibly some type of, could even be a seizure disorder in some way. So when you're getting that high intensity, low frequency, you really have, because they're difficult, if you're doing an FBA, they're very difficult to assess just because they don't happen that often. So when you get that pattern, you're going to look at what happens to the person during the episode, the intensity level, and then what are they doing while they're in the episode. A couple of these other ones, post-traumatic stress disorder goes without saying. And you're going to hear, if you do interviews or work with adults or even young kids that are able to express themselves, you'll hear things, that they were traumatized by some events. Important to look at in terms of treatments. Also, what's important on the treatment side of somebody who has post-traumatic stress disorder, if you can identify what the traumatic event was, physical abuse, sexual abuse, neglect, you got to make sure that your treatment or your intervention does not recreate that trauma. So if you're working with somebody that is sexually abused and using physical management with them, it's probably creating more trauma for the person. So if you identify it, you should be doing some other things. Assess what other things can be done. Adjustment disorders, we'll talk about that in a little bit. And we're talking people that go from high school, graduate to university, college. We're talking about people leaving home, going to community residential programs. Transitions, even for young kids, obviously, and we hear this all the time, making changes are a challenge. So they have these adjustment difficulties, and that's just basically what they are. They're adjustment difficulties, no different than us. If you've moved from your home or get married and go somewhere else, it's an adjustment. It takes a while for you to adjust to it. The challenge for us, or at least for the folks who have autism and making these adjustments, it's often it's kind of way beyond the way that typically people would make adjustments. And this is where you get the aggression and disruption. So my suggestions, and we'll talk about this later as we go along, you really want to, if you can, hold in there. You don't want to get again, medications. You don't want to start anything new. You want to have the person adjust. They may need a little bit more support, but after a period of time, they typically will adjust to whatever the setting is in with the support. Again, because they really don't have, and a lot of them don't have an alternative. They've just learned that I need to behave this way in order to make this transition easier. Psychotic disorders and schizophrenia, low incidence, I can tell you. It is low incidence in terms of the numbers of people. Again, it doesn't immune you from having psychosis, but when we're looking at the presentation of either hallucinations or delusions, these are the positive parts of psychotic disorders. How would you know that somebody who's nonverbal, that is profoundly intellectually involved, that is pulling things or picking things, how would you know that that's psychosis? It can be. Again, you would assess and find out what that's related to. And then your personality disorders. Again, another, even low incidence personality disorders, the ones that we see, that we'll see what's called schizotypal personality disorder, sometimes narcissistic, because everything revolves around the person. Things that you would question, or at least we would question when you see something that says antisocial personality disorder, or even borderline personality disorders, or something that it requires perspective taking, manipulation, and it's not something that most folks on the spectrum have. A number of people with PDD-NOS probably would be able to meet that one of those personality, the axis 2, and even with that, it's behavioral interventions, it's therapy, cognitive therapy. It's not medicines that are going to solve that particular issue. So types of symptoms that we look at, these are across a variety of areas. Neurovegetative, you heard that earlier. So anytime that you see a change in someone's sleep, whether you're a young child, adult, sleep patterns it's a key. Something's occurring that they're not sleeping, whether they're up more often, not sleeping enough, or they're staying in the room and sleeping a lot. Changes in appetite, obviously, are also very important. Affective, how does somebody look? And this, again, is important when you see these terms here. If you ask somebody on the spectrum, what do you look like when you're sad? It's in the responses you get, you'd be surprised at how they'll do a facial response. They won't tell you how they feel or how they look, but they'll make a face. That's how I look. So it's real important, again, to get to the level of how is it expressed in that person. Cognitive, I mentioned that way earlier in the presentation around even if you have a mild depression, that you're going to have difficulty with concentration and memory. In perceptions, that's your thought distortion, your internal stimuli. Those are in the area of psychosis, and something to look at. And how do you differentiate that from just somebody that may be perseverating or passions, as I said before. Depression risk factors, we look at family. Obviously, that's very important. We know that young kids on the spectrum that have depression, there's usually a family history, not in all cases, but there's a higher incidence of family history with depression. These are young kids that may be identified with depression. Any one of these things can affect mood and behavior. Worked with an adult not so long ago. A woman slept with her dog all the time. Her dog, she was very comfortable, loved her dog. Her dog died and changed her life. So in terms of not getting out of bed, not going to work, I mean, just something like that is important to look at as you're looking at symptoms or signs of depression here. There's some information and data. Just we will look at depression. We should know if you're, most folks, as I said, if you're higher functioning, you're able to identify symptoms of depression. If you're more socially aware, you're going to be able to identify, I feel depressed, I don't want to be with people, things like that. Subtle signs, wanting to be alone, talking about people passed away. I want to be with my grandmother and grandfather who died. So these are things that, again, change something different in the person that we really have to look more closely at. As I mentioned before about activities, preferred activities. Spontaneous crying episodes, welling up, people that will, just the emotions are right on the surface. So those are things that you would be assessing as well. And when we're looking at depression, for example, obviously we're looking at this onset and regression in terms of meeting criteria for something like that. When we look at change in eating patterns, irritability has increased, lack of interest in preferred activities. If somebody's presenting it, and there's these degrees, obviously, if somebody presents like that 2 or 3 weeks, the onset, then they would meet criteria for either a mild depression if they're not hurting themselves or having any kind of other co-occurring with the depression, psychosis, associated features. So we look in psychosis. These are these confused thinking, false beliefs. False beliefs, the food's going to kill me, the pink pill that I take is it's poison. I mean, these are things that people will say. So these are obviously areas of concern. Unpredictable mood swings and these sudden mood changes. Kind of when we hear out of the clear blue, these are the things that we would begin to look at. So in terms of the psychosis, you see autism and schizophrenia, it is a low incidence, but they share these clinical features. So if you look at poor eye contact, if you work in the field of schizophrenia, the people isolate relationships, the limited interactions, they have these poor self-regulation. It's referred to as behavioral flexibility. Go from this low level to explosion and back down so quickly, just like that. And and there's no modulation in the moods. So these are things that we would look at in terms of differentiating. But obviously the hallucinations are the things that are obviously major concerns of most people. Adjustment disorders, as I mentioned before, when we're looking at this, it's really this a significant response to even subtle changes can affect the adjustment. So don't do anything with regard to giving somebody medications. Again, you're going to look at the intensity and the frequency of the behavior. And you're going to go on that. But in most cases, just beefing up some support, helping the person understand when they're beginning to get anxious or escalated, and then we're going to give them ways to calm down. So those are some of the things around the diagnostic process. This is still in the diagnostic process. This is more with designing the behavioral plans or supports, or actually your therapies. So as I mentioned earlier about processing, these are things that are important when you're designing programs. So as we look at how does the person take in information, whether it's verbal, visual, auditory, that's really important. And then how does the person comprehend it? And we know with the ASD population, even superior range of intelligence folks have difficulty with executive functioning, organizing, sequencing, abstracting information, especially when somebody's agitated or upset. No different than us. If you're angry and upset, your ability to process becomes compromised. It shrinks. You're focused on the issue. So the processing really is important to know, is how much can they take in or understand at one time. Some of the things that we work on, at least in the areas of anxiety, social phobias, this behavioral flexibility, internal level of arousal, having a person identify that they are getting upset. In a lot of cases, the affect, how someone looks and how someone feels inside, doesn't jive. So that's why we do our self-assessment, self-monitoring. For young kids, you're going to have your thermometers or your measurement scales. How do you feel right now? That's really helpful. And even with adults that are doing self-reporting, journaling, that's really important to have them identify and understand that. So that when they know that they're getting upset, that's the first part, recognizing. And the second part is, okay, what do I do with this? Something that's more acceptable than the negative behaviors that oftentimes you may see in the process of somebody just kind of melting down. And then these impulse control. So just a very quick look schematic-wise here. So you look at this input. We have, in this, these are some of the ways that, for people who have impulse problems, you see on the far end the behavior, the aggression or self-injury and noncompliance. For people that are impulsive, this is typically where we intervene in most cases. When the behaviors are presented, and even things that may be punitive, even things that may be restrictive, is not enough to inhibit that person from their impulsivity. So when you're working with someone that you have interventions on the backside, person has a problem, loss of activity, you can't have access to wherever you're going, and they're still having their problem, it will not work. You won't be effective. So we have to go on this front side, understanding settings, events, directives, people around them, and then this internal level of arousal. Processing piece, the thoughts and perceptions. For every activity anybody has, we have thoughts and perceptions about this. These are clear and true thoughts. You know, we clearly understand what's going on. If you have a mental health condition, OCD, if you have psychosis, then those thoughts and perceptions are going to be skewed, atypical. They're not going to be clear and true. So we have to make sure that those input things are very clear and true. And then our thoughts and perceptions, we have emotions that are attached to that, and that's what we behave. We act on those emotions. So the vulnerability of the people that we work with is in the emotions. So as you see, if somebody is in an environment that they're overwhelmed, they're in the bowling alley, they're overstimulated, the thoughts and perceptions are probably confusing. Emotionally, they're upset. Internal level of arousal is heightened. And you don't have to have autism. It can happen to anyone. If you are angry and upset and mad, you're more likely to do something impulsively. Your threshold for saying or doing something impulsively is there. And that's why we behave. So for somebody, and this is just a pattern for anybody that you're working with, on the front side, clear expectations. Press, in terms of thoughts and perceptions, you clearly understand what are we doing here. Even in your therapy sessions, as you'll see a little bit, it's important to check and monitor all the way through the session, including the tail end of it. And then giving the tools to that person once they become upset to de-escalate. So that's our job to help them. The only thing I'm going to tell you about functional behavioral assessments, it's very important to complete a functional behavioral assessment. There's a variety of ways that this is done. I mean, you can do indirect, meaning that you can ask the person, you can ask the family, you can ask teachers or support staff about when do these things occur, what do they look like. The two critical things, obviously, are form and function, meaning that the form, how does it look? Just not aggression or self-injury. What's self-injury? 3 times to the side of the face, biting the right hand, the index finger. That's real important to be that descriptive in terms of giving you information, because you're going to be looking for changes in that. So the person still may be self-injurious, but it could go to something else based on your intervention. So the detail in terms of how it presents is critical. And the reason why we do FBAs, if you folks are involved in that, this should be required. So whether you're a parent, whether you're an individual that's getting treatment, if you're having some concerns, you would want somebody, tell me what's going on with this. Give me some more information about why I do this, where I do it, how it's done. And again, there's a variety of ways to do it. And it's really based, the FBAs have been around since the mid-'70s. They're more focused nowadays. They're required in all behavioral health. So it's a good idea to do that, because that's going to really direct your interventions or treatments. So the 6 steps here, as I said, this form, topography. How is it expressed? How is it looked? The function, it's going to get to the function. What's the etiology of it? So now that you know the person, what's autism? How is autism presented in that person? What's the behavior look like topography-wise? Where does it occur? And the other important thing is, too, not only where does it occur, where doesn't it occur? Because when we think about behaviors being motivated, right? There's a motivation. It's attention. It's escape avoidance. It's internal. It's sensory. When we don't see the problems, that means that every motivation is being met. Every one. The person doesn't have to have the problem. So what's important and the key, at least for me, is to look at what's going on in that person's life at that moment, at that time, because that's going to be part of your answer, your interventions. Then you're selecting this data system as well. Analyzing the data, the hypotheses, designing the support plan, and then you're going to monitor and track. So it's all under this label of applied behavioral analysis. So getting an idea of the etiology, what does it mean to the person who's exhibiting the behaviors, and now that you know those 2 things, then we can teach them something else to do. These are motivations in every area. So we look at why would somebody have challenging behaviors. Everything from the biological side. I mean, there are people with genetic disorders that there are challenging behaviors that are associated with the genetic disorder. So we have to look at that as well. And doesn't mean that we don't treat it, but we at least know a little bit more about it or why it's expressed. Physiological, hunger, thirst, pain, all the way down to this sensory area. So as you see, it's across every area, every domain. And that's it's important to get information on that. The interventions, the reason why we do interventions, behavioral plans. So we've made a shift, I guess, and I was trained in behavior modification in the old days. Everything's still behavioral, but we've moved from this modifying reduction mindset, let's eliminate or get rid of the problem, to really behavioral support, functional behavioral assessment, and designing support plans. So we're not managing behavior, we're teaching alternatives. So it's positive behavioral supports. And it's important. The more involved, if you work with folks that are intellectually, that have an intellectual disability, you're really going to have to do a lot of things before you implement your program. Everything from guardian, are there advanced directives, there are things that I need to know about this person that we wouldn't do these behavioral interventions. And then you're going to have to check probably with about 20 people before you start your intervention, which is great, but you just have to know it's difficult just to design a plan and start doing it. And the reason why we do these plans is obviously to make the behaviors irrelevant, ineffective, and inefficient if we're good at identifying that. Best practice biopsychosocial models. So, and recovery is part of it. That's on the mental health side. So recovery and resiliency is mental health. And it's important. Hope, peer mentors, and some of these folks that we're talking about here have peer mentors. They have been in the system, they have autism, and they're helping other people. Self-advocates, for example, will be involved in a lot of the treatment planning. Biopsychosocial model, so you're looking at biological, understanding biological history, the medications, biological treatments, then the psychosocial, the developmental part, and the social interaction. Categories of treatments, the only thing I can tell you around this is that when we look at all the treatments out there for autism, there are so many. And in terms of what ones do you recommend, it's all individualized. But I can tell you, you're probably going to go with ABA, as you heard, even from a billing standpoint. The applied behavioral analysis interventions are the ones that will be covered. Those are the ones that you'll probably choose and would be recommended. Doesn't mean that these other treatments that don't have a lot of research behind them aren't effective. It just simply is you're going to go with things that are stated, things that have worked and have demonstrated. But again, it's individualized to the person. You can't say that that will never work just because I've said that in the past. And there are things that people do that you're just surprised how they respond to it. So treatment principles: conduct the FBA, develop a hypothesis. Looking at the medicines, as I said before, if you're choosing a medicine, ask the questions. What's that medication indicated for? How long should it take for it to work? What are the side effects that I need to look for? And then monitoring and tracking that. If you're on medicines for people who they have these motor side effects, so if you go to the doctor's office, make sure that somebody's doing some kind of a side effects profile. There's the AIMS and the DISCUS. Those are routinely done. Nurses usually do them. It doesn't take a whole lot to do them. Again, just helping for your mindset if you have a family member that goes in, or if you're on the medications, you want to know, is everything okay here? Talked about this best practice models, biopsychosocial. We talk about generalization. Ben and Cindy were talking about their programs, training parents. It is very important that whatever you're doing, whether individual therapy, group cognitive behavior therapy, that intervention can be generalized outside of your office. Because a lot of times we can do things in our office, people respond really well, but we don't think that, well, how can they use this at the Giant Eagle, or how can they use this at Kennywood, or wherever they are? It's real important to do that because that's how you're going to apply that. Interventions are based in positive approaches. There you see that term there, medications before motivations before medications. All right, so a couple things on the therapist, and Marty will do a couple of things here on the medicine issue. Just a quick couple of things on if you're counseling or using therapy. So this is, when we talk about best evidence-based, first of all, there's not a whole lot of evidence on what is the best type of therapy in terms of talk therapy. We do know that any kind of therapy that you use, if you're using experience in it, some hands-on, some visuals with homework, we know that those are really kind of the best components to use. The insight therapy, how do you feel about it? Tell me what your experience is. That's much more challenging for someone to be able to describe, especially in a group session. So talk therapy alone. If you're using the psychotherapy or DBT, dialectical behavior therapy programs, they really are more beneficial if you're using some assignments with it, some visuals, some modeling, and some demonstration. Therapist considerations, again, if you don't know autism, some of the ways that the person looks, avoids eye contact, low modulation in their tone of voice. They may, again, you think they're hiding something. It's just not the way it is. If you, again, know the population, even the sensitivity to criticism, I can tell you this. When you're looking at the communication, when you're working with somebody who's communicating, you can use correction at that moment for the things that the verbal interactions. But you really want to stay clear initially on your first probably 2 weeks, week or two sessions, anything that criticizes the nonverbal stuff. Look at me, turn around in your chair, because I can tell you it'll turn somebody off very quickly and they won't show back up in your therapy session. So there's nonverbal things, you can address it, but you really want to address the verbal things that person can use over, you can practice it with them. And so these are things to, again, to be cognizant of. So cognitive behavior therapy, OCD, Asperger's, Tony Atwood has great models for this of when to intervene, what to use. We see experiential, it's doing with the person, modeling and demonstration, family and caregiver involved in, and that's very important. So you want everybody involved. in again, the generalization part, and it's going to require signed releases and all of that. But the point of this is it will, you'll have better effects and better outcomes if you have more people involved in it. Jeffrey Wood, these things are available. You can get these online. As I said before, this is treatment of CBT, cognitive behavior therapy. It's really breaking situations, events, experiences down into smaller components. In this case here, we're talking about somebody who has anxiety, and a lot of the folks that we treat will have anxiety or some kind of social phobia with regard to the treatment end. So first phase, understanding it. Physiologically means, what are you doing? Are you rocking? Are you breathing heavily? Do you have these shallow breathing? Am I sweaty palms? I mean, these are things that people can identify, and that's really important. That's going to help them. Cause and effect, sequence of things. A lot of times, again, even folks that are very, very intelligent really have difficulty with the sequencing events. They can understand cause and effect, but what happens in between that? And those are the things that really are important to know if somebody's anxious or disruptive, what occurred. Skill set, social skills training, and practicing. So our CBTs, I'm going to run through this stuff very quickly. So this is cognitive behavior therapy. Usually they're time limited, they're brief, small groups, 4 to 6 people. Again, you got to make sure the mix is good, and it's usually in probably 14 sessions. So it's brief in ways, and then you see all of these things. It's very structured. There's homework assignments for anything. If you're providing therapy, these are important things to do. In terms of breaking it down, you're going to be also doing a check when you leave your session. What did we learn today? What is the assignment? Because a lot of times if you just leave, it's over, you're gone, and you think that you made some inroads to some of the symptoms or things that you're treating. But if you ask the person, what did you get from that session? Nothing. So make sure that you're clarified before you leave, couple of minutes, so that the person clearly gets it. I've asked people that have been in treatment for a long time, is this treatment beneficial for you? And they say no. And why? And even ask them, did you ever see a treatment plan? They say no. Well, what are you treating? So as much as you can tie the person in to their treatment plan, understand what they're doing, give them ways to monitor and track. Are they getting better? That's where your self-assessment and self-monitoring comes in. With regards to anxiety, we have this psychoeducation. You see these, there's different ways you do it. I've had these are adults now these are for anxiety. Even going in to get a coffee somewhere or engaging in kind of conversation with someone. We had people that would go to Toastmasters. I don't know if you're familiar with it, but they actually teach them how to talk in front of people. It's a good way to do it. You can also videotape these things. So video modeling, Ben and Cindy were mentioning about, there's a couple of video modeling programs. Cognitive restructuring, it's a technique, it's CBT program. So you're going to look at the whole event. You're going to see what that person does. If they get anxious at the mall, they start to escape and avoid, then what you're going to be able to do is have that person, first of all, identify what it is, what causes this thing, what do you do when this happens, and then your job, obviously, is to teach them something else. And that's desensitization in vivo. So it's actually going out into the field and doing that. We have a person, adult, that we're working with that has difficulty, it's unusual, but has difficulty just going to a movie. So part of the job is to demonstrate what it is what thing that makes you upset or that you can't get into a movie. And this fellow was in film, actually. He was in California, and his area is filmmaking, but he won't go into a theater. So we're working with him on how do you get into this theater? What is it that creates that anxiety? So our goal is for him to go into a theater. We have somebody in the audience here that's working with actually this person. Social skills training, and I'm going to wrap this up. So social skills, it's different than this. If we look at, is this a social skill deficit or is this truly an anxiety problem that we're working with? So on the social skills side, this is a more recent study that looks at, again, the components. High degree of structure, predictability, teaching, again, warm up. Sit down, this is what we're going to do. Clear expectations. Do you have any you're clear of what we're going to do here in this session. Let's get through this. You'll have homework assignments, the two-way, the teaching, and then you're not leaving it up to the person on their own, like in individual or psychotherapy, that they're left to their own resources. And then the last thing I want to say, we have this technology that you can, we're using a lot of these things with iPads and iPhones. So we can do things from scripting for family events. We have adults that when they go to their family events, these are people that are married, but when they get into the family events, they're usually sitting by themselves. Nobody approaches, so we'll actually have them do their iPhones, scripting. You're going to go and see your sister-in-law, and this is what you're going to ask her and talk to her. So even before they get in, they're prepared for what they need to say or interact. So once they get in, then they're able to navigate. So there's a lot of things, even medications. There are iPhones that it's time to take your 12 o'clock med. So a lot of times people will miss their medication. So you can do auditory, medication time, and even specific pill that you want to take that can cue you when to take them. So there's a lot of things that School of Rehab that I'm a faculty member of, they're doing it with their populations. All right, so with that, we're running short, and I know Marty wants to say a few things, just a couple things on meds. So
I'm just going to hit a couple pearls because we're actually over time already. In regard to selecting a medication, again, there are no FDA-approved medications in autism. There's only 2 in selected symptoms of autism, and I'll mention those. So going through a few medication classes, even thinking about adults, sometimes stimulants may be appropriate for selected symptoms of ADHD and attention distractibility, impulsivity, hyperactivity. There's not an adult study, this is a child study, which showed that at least there is some response to stimulants in the autism population, not quite as good as in normally developing children with autism. And there are non-stimulants that are also used in ADHD. Again, most of these are based on child studies because there aren't adult studies. Strattera as a non-stimulant, and then clonidine and Tenex, which both have long-acting versions that are now approved in ADHD. Strattera is approved in adult ADHD as well, but again, not specifically autism. The one large study in risperidone in autism, again, this was in children, not adults, but clinically it has been used in adults, and it has shown improvement in selected symptoms. The specific symptoms relate to, as the FDA has approved in 2006, irritability, aggression, deliberate self-injury, temper tantrums. And again, this study was in children, but clinically it's being used in adults as well. And certainly for any of these medications, you have to monitor both effects and side effects. And the side effects in this group of medications is mainly weight gain, but also looking at sedation, constipation, and monitoring glucose or blood sugar, and monitoring lipid panel or cholesterol. Abilify or aripiprazole was also approved in 2009 as an FDA approval in autism, but again, the same selected symptoms, irritability, aggression, self-injury. Again, this study was in children, but it has been used in adults. And in the study, they showed dosing starting roughly 5, 10, 15 milligrams, so that you're starting low and then you're titrating up so that you don't get to too high of a dose. And this group of medications, the atypical neuroleptics or antipsychotics, mainly used in psychosis and mania, but also looking at aggressive, impulsive, agitated behaviors in autism. So risperidone and Abilify having been approved, FDA approved in autism, and Zyprexa, Seroquel, Geodon certainly are being used in this population. Zyprexa having the most weight gain and Geodon having the least likelihood of weight gain. The FDA advisory is what I mentioned about how you monitor. Antidepressants have been used specifically for depression or anxiety disorder, but also symptoms, anxiety, rituals, compulsions, and sadness. There have been a few small studies in adults. Prozac or fluoxetine, which was the first one out, has had the most small studies. All the other antidepressants have been used. The Celexa study, again, was in children, and it showed no better than placebo for repetitive behaviors. It wasn't focused on anxiety symptoms. This study was only focused on repetitive behaviors. There's a fairly recent study out in adults looking at Prozac that showed some mild benefit. And again, I still believe that it's more anxiety type of symptoms that it's most beneficial in. The other non-SSRI medications, Effexor and Wellbutrin, I also listed. The FDA has warnings, again, how you monitor, and specifically looking at agitation and looking at possible signs or symptoms of suicidality. And for all of these medications, it's really monitoring frequently, having contact not only with the individual but family and caregiver to monitor it safely. The last group of medications focused on bipolar disorder, mood lability, and aggression. And lithium is the one that has been used the longest in bipolar. But all these other anticonvulsants have been used for mood instability. There have been a few studies looking at Depakote in both children and adults in autism. Sometimes the belief that since autism is a brain disorder, about a third of the population may have seizure disorder. Some have thought Depakote may have some benefit. But again, if it's not being used for seizures, the focus of this group is more mood lability and aggression. Because you have to monitor blood work in several of these, you really have to know that you can safely monitor the medication before you would consider starting it. Many side effects in the anticonvulsants that I won't go through, but as I mentioned, the blood work monitoring is most important. At the end of the PowerPoint, you'll see that we listed several websites and several references for some of the information that was provided. So my summary about medication in adult is similar to in child. We don't start with medication. You really need to start with the large team approach. If it is cheaper or easier to medicate than to do the more intensive behavioral interventions, that's still not a good reason to jump to medication. And certainly one thing I do when I see individuals from other practitioners is start to really assess each medication and sometimes reduce the number of medications or assess the dose of the medication. So really working in that large team effort is what's critical in regard to medication. So I'm sorry that we ran way over. We're going to end now. John and I will hang around for a few minutes. Thank you all for being here and staying so long on Friday.